one. We honored to have Mr. Ahmed Youssef. He's a consultant otology and neuro-otology, skull-based. He's one of the amazing mentors. I've been under his care and mentors as he was my mentor in my skull base in University Hospital. So it was really honored to work under him and with him as well. I've learned a lot, to be honest. One of the most exciting things that I was knowing it, but he make it more simple and easy and easier than you think and thought, is the vestibular function test. So when I've seen him, I say that, would you mind just to come to say the small words that you put it in my mind and make it together for everyone as well? And this is really, really important for who wants to build up career in ENT, especially general or otology, because you get a lot of dizzy patient. So thank you for acceptance of our invitation, Mr. Youssef, and you can start.
Thank you, Abdurrahman, for the kind of very humbling introduction, I have to say. Thank you so much. So we'll try to go through the assessment of dizzy patient and the vestibular function tests in the next hour. So, okay, all right, so we're having a glitch. Oh, all right. Okay, so what we're going to try to achieve is a look at how to take proper history, perform clinical vestibular examination, and also differentiate between different peripheral vestibular disorders. And we'll have an overview of the vestibular function tests. So just to quickly, I mean, I don't want to waste time on this, but it is just an opening thing. So why do we normally, as ENT doctors, find it difficult to see dizzy patients? There are actually genuine reasons for this. As you know, the physiology for balance is a lot more complicated compared to physiology for things like hearing, for example. Also, the patients can come with a lot of vague symptoms. You can't see the target organ. So when you see, for example, somebody with earache, you can easily examine the eardrum and see if there is otitis media or not, but you can't really examine the labyrinth directly. Also, the investigations, as we will see later, has got low sensitivity and specificity as well. There is very limited treatment options when you think of how many times you had to operate on dizzy patients. Also, the medications available for dizzy patients are also kind of vestibular suppressants. So there isn't a great deal of options that we can use to treat dizzy patients. One of the other, I think, important reasons why it's difficult is the presence of central causes and systemic causes. So everybody, most likely, if you are had a recent training or decent training, you will be able to manage the ENT causes, Meniere's disease, BPPV, vestibular neuronitis. But the problem, of course, is that you see the patient and you try to slot them in one of those ENT slots while you can't, and that what makes it difficult. And one of the reasons is that it could be something that is not actually related to ENT. Also, the significant association between dizzy patients and psychogenic causes or mental health issues, including anxiety and depression, makes it also very difficult to deal with these patients. So if we start with the history, so the history, they all say that if you finish the history taking and start examining the patient without having a provisional diagnosis in mind, you're most likely that you'll end up with the same situation after the examination. In other words, the history is of utmost importance, and that's why it takes time, and you need to give it time to be able to benefit out of it. So what do we want to achieve from history? We want to find diagnosis or come up with diagnosis if possible. We want to assess how severe the problem is, and also may help in management aspects. So first of all, the patient comes in complaining of dizziness. The There are definitions of vertigo, which is unreal sense of rotatory movement; dizziness, any kind of altered sense of orientation; lightheadedness, which is a sensation of unsteadiness, could be fainting or pre-syncope. And the lightheadedness are mostly non-vestibular, could be cardiac in origin. Imbalance, which is inability to maintain the center of gravity. And the imbalance could be sensory because there is a problem in the vestibular system, but also could be motor. So the patient has got musculoskeletal problems, for example. And it happens every now and again, not very often, but it happens that we see patients in the balance clinic because it is called balance clinic. And when you ask them, do you feel dizzy? And the patient comes and says, no, I don't feel dizzy. I just lose my balance. And this could be simply due to something like arthritis or hip problem, knee problems. But I have to say that these definitions are of academic interest because the patient is not a doctor. They won't come in and say, I've got lightheadedness or vertigo, and this would mean the same to us like what it is to them. So the patient comes in and says, basically, I've got dizziness. So when you want to analyze the dizziness, what you want, or the vertigo symptom, what you want to find out is the duration, because this will help in etiology, as we'll see in a second. You want to identify how often does these episode of dizziness happen, because this would indicate the severity. So if a patient gets one episode of Meniere's, for example, every 6 months, is completely different to somebody who gets 4 or 5 episodes a week. Then we move on to the precipitating factors. So if the patient can identify a precipitating factor, and just before we go through the rest, as you'll see at the end of this, is that I always look at the dizzy patient as a puzzle, or more accurately, a jigsaw one. So you will find very little where there is one test, one examination that will give you the answer. It's always bits of the jigsaw puzzle you put together until you can see the picture at the end. So if you are lucky to have a patient who's switched on and really helpful in terms of telling you precipitating factors, this could be something like a position, in certain position, for example, the BPPV, or if they say that every time I stand up, I feel dizzy, then could suggest something to do with the blood pressure. Noise-induced dizziness, Tullio phenomenon. This could be superior semicircular canal dehiscence, and straining, which could be perilimb fistula, superior canal dehiscence, or Arnold-Chiari malformation. Then we move on to the associated symptoms. So there is a trigger, and there's also symptoms that happen at the same time. They could be otologic symptoms, like, for example, cases of Meniere's disease, where patient can suffer from tinnitus, hearing loss, and fullness. They could also be in the form of headaches, phonophobia, photophobia. It could be suggestive of migraines, panic attack symptoms as well, because these patients, as a part of the panic attack, they could be feeling dizzy. Palpitation, arrhythmias, and sometimes it's difficult for the palpitation or for the patient, to identify which happens first, because especially early on, when the patient is severely dizzy, they will be anxious, their heart will race, and they will suffer from palpitation. If the patient is able to identify which of the two happens first, whether they go dizzy and then their heart starts pounding, or their heart starts playing up and then they go dizzy, this will be very helpful. But again, as I said, it's relatively difficult for the patient to ascertain that. And then we move on to things like vagal symptoms, nausea, vomiting, and sweating that can happen with dizziness. And vomiting is quite important symptom to acknowledge, because this means that there is a genuine severe attack of dizziness. That's why the patient is vomited. So then we move on to the otologic symptoms. Of course, it will be embarrassing if we, as ENT, miss a case of complicated otitis media where there is discharge and it's causing labyrinthitis. After we finish all this, then these are things that I specifically ask the patient about, even if the patient does not volunteer to report them to me. So if there is any cardiovascular diseases, for example, including anemia, any psychological problems, anxiety or depression, visual errors. So a lot of times we see elderly patients come in feeling dizzy and they go away, they have cataracts, they go have it done, and the dizziness disappear after the cataracts gets treated. Also musculoskeletal symptoms. So the patient can be, so the dizziness can be mild, but the patient is falling over because they've got severe arthritis that they can't stop themselves from falling. So, and this will also have an impact on the management and treatment. Migraines, even if the patient does not, as I said, volunteer to report that, I would specifically ask about migraines as well. And sometimes they're not even diagnosed with migraines, they just get headaches. So after the history of present illness per se, move on to the past medical history. Is the patient diabetic? Is the diabetes controlled? Because they could have peripheral neuropathy, and the diabetes actually can affect the balance and the dizziness in multiple areas. It can affect the inner ear the same way that it's affecting the hearing and makes the patient prone to sensory neural loss. It can affect the cerebellum. It can affect the proprioception. So the diabetes, the uncontrolled diabetes, could be responsible for significant dizziness. And I have to say that it probably not going to be presenting in the form of rotatory vertigo, but it will be, it could be playing a part in patients who suffer from dizziness. Hypertension or blood pressure in general. We know that high blood pressure, low blood pressure, fluctuating blood pressure, all these can be a cause for dizziness. A lot of times I picked up patients developing hypertension. They're not aware that they've got hypertension and they just presented to us with dizziness. Drug history is important, again, because a lot of medications, as you all know, have side effects of dizziness. For example, if there is ototoxic medication that the patient got exposed to, including aminoglycosides in general, loop diuretics, chemotherapy, they can be responsible for bilateral vestibular deficit. Side effects, most of these, so the cardiovascular ones, the psychotropic ones, the hypoglycemics, the antiepileptics, vestibular sedatives, all these can cause dizziness. And the issue or the problem happens is that, especially in relatively elderly patients, they are on polypharmacy. So they are on 10, 11 medication, and some of them would have side effects of inducing dizziness, and it may not necessarily be the cause of dizziness, but it could be adding to the problem. And I have to say that unless there is an obvious temporal relationship between the dizziness and the start of the medication, that would make it slightly tricky and difficult to diagnose a drug-induced dizziness. And sometimes I ask the GP to temporarily stop the medications that can be stopped. Of course, I mean, we won't be asking them to stop the antiepileptics or the hypoglycemics, but if statins, if other medication that can be stopped temporarily, especially if there is a high suspicion that they could be the cause of the dizziness. Then family history, we know that certain conditions like Meniere's disease, migraines, tend to run in families. And social history. So has the patient been drinking alcohol, lots of alcohol at any stage in their lives? Because they may not necessarily be drinking now, but they may have had alcohol problems that damage the cerebellum, which is the main conductor of the balance in the past. What do they do for a living, for example? Because this would affect relatively the management, the urgency. Do they drive HGV? Do they climb roofs? So all these things need to be considered. Have they got family at home? Is there anybody that they can support them, or do they live on their own? And that's from the history. So just this is a very simple, basic table that just shows you how or apply the duration of the dizziness and the presence of other symptoms like the hearing loss, for example. So if a patient complains of dizziness or vertigo that happens for seconds and no hearing loss associated. This could be BPPV. If there is hearing loss associated, perilymph fistula could be. And I have to say that perilymph fistula is very, very rare. So think twice before suggesting that that's the diagnosis. If the dizziness lasts between minutes to hours and there is no hearing loss, this could be migraines, could be vertebrobasilar insufficiency. Recurrent vestibulopathy is basically repeated episodes of rotatory vertigo, and that's it. Most of these patients would turn up eventually to be either migraines or Meniere's disease. And if there is hearing loss, of course, and the dizziness is lasting minutes to hours, it will be one of the Meniere's family, either the Meniere's syndrome or the disease. It could be Cogan's disease if there is some scleritis with it, but it is basically a form of Meniere's. If the dizziness is lasting for days and no hearing loss, then you suspect vestibular neuronitis. If there is if it's lasting for days and associated with hearing loss, this will be labyrinthitis. Weeks could be something central, like MS, for example, if there is no hearing loss. If there is hearing loss, you could suspect vestibular schwannoma, could be an autoimmune. And as I said, this is just a very basic one, but it just helps you to think or to basically organize your thoughts. And also it shows the importance of the hearing test. The thing is, there are some colleagues who sees balance or dizzy patients without having a hearing test, especially neurologists. And I think that that's probably shouldn't be happening. They need to get a hearing test to see, because it makes a significant difference if you see a patient with dizziness and they've got one-sided hearing loss or they don't. So if we proceed to the examination now, so in general, the plan that I normally take is to do a full ENT examination, cranial nerve examination, cerebellar testing, and then we're going to move into the nystagmus testing, oculomotor testing, and head shake nystagmus, head thrust test, dynamic visual acuity. As you can see, the first three, these are, everybody knows how to do them: cranial nerve examination, cerebellar testing, because if there is an abnormal or if there is some cerebellar signs, then this patient needs, of course, to be seen by a neurologist. The nystagmus testing and the oculomotor testing, their aim is to see if we are dealing with a peripheral vestibular problem or a central problem. The ones in the red here, I am actively checking or looking for signs of a peripheral vestibular lesion, which is, I will come to these in details. So we'll skip, of course, the ENT examination, the cranial nerves and the cerebellum, and move on to the nystagmus testing. Before moving into this, we move into positional tests and postural control tests, and could be other tests, and we'll come to this at the end. So if we want to test for nystagmus, you look initially for spontaneous nystagmus. Ideally, you would want to have Frenzel's glasses, because, as you know, the peripheral nystagmus, or the nystagmus of peripheral etiology, gets reduced by fixation. So I know it's not available everywhere, but there is actually a very cheap Frenzel-like glasses where you can get it from Amazon. They are not the best, I have to say, but they still do the job, and they are cheap as well. Basically, when you look at spontaneous nystagmus, you want to identify, if you find it, you want to identify the direction of the nystagmus and the degree of the nystagmus. Of course, we all know purely vertical or purely torsional nystagmus would suggest central nervous system lesion. Then if you find the nystagmus, it's important to know if it is a central or a peripheral one. So, and to know that, you know it by the direction of the nystagmus. So if the nystagmus is unidirectional, i.e. the nystagmus is right-sided nystagmus or left-sided nystagmus in all direction of gazes, that's a unidirectional, and that fits with a peripheral one. If the nystagmus is direction changing, so it is, if the patient looks to the right, it's right side. If the patient turns to the left, it's left side. That's a central one. The character of the nystagmus, is it a biphasic, meaning that there is a slow phase and a fast phase, or is it a pendular one? And the visual fixation. So if you find a patient has got a spontaneous nystagmus, ask them, even if in A&E, ask them to fixate on a target. If the nystagmus reduces significantly, it should reduce by at least 50%. So it's not something that you would try to convince yourself that it's gone less. It is a proper suppression. Then that's a peripheral one. If there's no obvious suppression with fixation, you have to suspect central lesion. This is just a video from Fiona Barker, who is a audiological scientist. And this is, I find, we're going to use her videos as we go along. This is just to assess the nystagmus.
This can be done using Frenzel glasses or with video goggles. Some of these have a single camera and some can film both eyes. These are the most commonly used methods in ENT and audiology departments. Some video goggles have fixation lights inside, so you can easily assess the effective visual fixation as well, but always ensure that the lights are off if you are testing without fixation. For a patient with a peripheral lesion, any nystagmus present should be enhanced when fixation is removed. It should also follow Alexander's law.
So you can see here in the video that she put in is that the nystagmus gets very obvious after a removal of the fixation. And then after looking for spontaneous nystagmus, I specifically look for gaze-evoked nystagmus. So basically, you ask the patient to fixate on your finger or pen to the sides of the center and see if there is gaze. If there is gaze-evoked nystagmus, which means that when the patient fixates on the target, they start to develop nystagmus. This could indicate a central pathology as well. Just be careful of the physiological endpoint nystagmus. So if you put the target that the patient needs to look at way across to one side, then this is the patient would develop a temporary nystagmus because it's called physiological endpoint nystagmus. And a lot of times we see that from GP referrals saying that the patient has got nystagmus looking to the right, and when you assess them, you don't see any nystagmus, and it's just basically a physiological one. So again, that's a video about the gaze-evoked one.
In front of them. 30 degrees to the right and left, up and down. Endpoint nystagmus may be present in the extremes of gaze, but it will be transient. True gaze-evoked nystagmus will persist. Note the direction and nature of any nystagmus and which positions it is present in. With a peripheral vestibular lesion, the intensity of nystagmus should increase when the patient looks in the direction of the fast phase. This is Alexander's law. This patient has a right beating nystagmus present in all directions of gaze, but it is more obvious when he looks to the right. This patient has a subtle rebound nystagmus, which you can identify with gaze testing.
And then we move on, after testing for the nystagmus, we move on to the oculomotor testing, which is basically the smooth pursuit eye movement and the saccades. In the smooth pursuit eye movement, you ask the patient to follow a target. And what you want to look for, if there is any disconjugate eye movement. If there is disconjugate eye movement, means that both eyes are not working together. This could suggest the presence of an MS, basically. If there is saccades in the smooth, so the eye is not moving smoothly, there is like cogwheel eye movements. This could also indicate a central problem. At the saccades, you ask the patient, as we'll see in the next video, to look at the target and see if the patient actually can look at the target and whether there is a delay, if there is overshooting. And both of the oculomotor testing would suggest a central pathology. And again, as I said, it's one of the important questions that you need to answer at the end of the examination, whether we're dealing with a peripheral problem or a central problem that needs to be addressed by or seen by the neurologist. So again, we'll see here how the horizontal and the smooth ones.
Even people with normal pursuit are usually better at doing horizontal rather than vertical movements, and performance is affected by age and attention. You may need to do the test more slowly with an elderly patient. Pursuit may be impaired in one or both directions. Peripheral vestibular deficits do not affect pursuit unless there is a very strong spontaneous nystagmus. So abnormal pursuit suggests central, generally vestibulocerebellar involvement. This patient has impaired pursuit on rightward eye movement, but intact pursuit to the left.
Okay, then we move into or looking for the signs of peripheral vestibular lesion or deficit, the head shake in nystagmus. So the head shake in nystagmus is done, could be done under Frenzel's or eye closure, and you shake basically the head to both sides, 10 degrees, 2 cycles per second. And if it is positive, this is an indication of a peripheral vestibular lesion. So as we could see, we look for any signs of central pathology through the cranial nerves, the cerebellum, this nystagmus, the smooth pursuit, and then we head into trying to actively find if there is signs of peripheral vestibular pathology. And that's how we do the head shake nystagmus.
Ask the patient to close their eyes and tilt their head down by 30 degrees. Then move their head back and forth 20 times reasonably quickly. After 20 oscillations, stop suddenly and quickly put on goggles to remove fixation. Ask the patient to open their eyes and look for nystagmus. If 3 or more beats are present, it implies a vestibular imbalance. Note its character, duration, and direction.
When I personally, if I do it, I don't necessarily do it under goggles. I still think you can catch it. It depends on, of course, on how strong it is. As we agreed, the fixation would reduce it. But if it is a strong, or the patient is relatively in the acute, subacute phase, you should be able to see it. Then we move on to the head thrust, which is definitely, I do it in almost every patient in clinic. And we are looking for a refixation saccade, and this, if you concentrate on it, because we will use it in the testing a bit later.
degrees below the horizontal. This brings the horizontal canal into the plane of motion. If the patient could do this, move their head quickly to one side and then the other. Obviously, it is important to warn the patient that you will be moving their head quickly before you begin the test. A corrective saccade after the thrust indicates a decrease in VOR gain and implies a vestibular loss on the side towards which you are moving the head. This lady has a unilateral loss on the right side. This test has good specificity but lower sensitivity. Normal performance does not preclude a vestibular weakness. Watch again for the corrective saccade after rightward but not leftward head movement.
So this test is actually quite important because, as she said, having a negative test does not rule out a peripheral vestibular lesion, but a positive one would definitely indicate that this patient has got a peripheral vestibular lesion, and it will tell you actually also which side. It is very important, especially in the acute setting. So if you see a patient in A&E for any reason and the patient is dizzy or severely dizzy, they are vomiting, the first thing that you want to answer is that is this patient having a stroke, or have they got vestibular neuronitis? So if the test is positive, then this means that it is most likely a vestibular neuronitis and less likely to be a stroke in the acute phase. The reason why you can't see it, and again, we'll come to this a bit later, in some patients who had vestibular neuritis a long time ago because of the compensation. So these patients have compensated, and as they compensate, the likelihood of you picking up this positive head thrust test becomes less and less. Then the third test for a peripheral vestibular lesion is the dynamic visual acuity test. And basically, you passively rotate the head for 5 to 10 degrees and ask the patient to look and read the Snellin's chart. If there is a drop in the lines that the patient can read, this indicates vestibular loss. And again, the reason why a normal person can read the Snellen chart with the head being moved from one side to side is because they've got an intact vestibular ocular reflex.
You move the head 2 Hertz. The amplitude of head movement required is very small, only 5 to 10 degrees in either direction. There is no reason why the test cannot be done with the patient sitting down. It is important to move the head at least 2 Hertz to prevent the patient from using pursuit to track and read the letters. It may help to use a metronome.
Okay, and then we go on to, so far we've done the ENT examination, the cranial nerve examination, the cerebellar testing, and then we did the nystagmus testing and the oculomotor tests, including the smooth pursuit and the saccades. And then we looked for the peripheral vestibular lesion. Then we move on to the positional tests. So I don't want to waste your time telling you how to do the Dix-Hall-Pike test. The role test is to test for the lateral semicircular canal, but then we move into the postural control tests, which is the Romberg's testing and the stepping test. The Romberg's, we all know that if it is positive, it could be deep sensory loss, it could be acute unilateral vestibular lesion or chronic lesion. The postural testing, they do not help in terms of the diagnosis, but they give you an idea about how bad things are in terms of the patient's symptoms. Again, the stepping test, whatever you call it, Unterberger's or Fukuda test, patient can go 50 or 30 steps. If there is 30 degrees or 45 degrees rotation, that would indicate or could indicate a peripheral vestibular lesion. Most of the times the patient would deviate to the side of the lesion, but not necessarily. Sometimes they do deviate to the opposite side. I think we'll skip that one. And then finally, one of the tests that I find very helpful, again, it won't give you a diagnosis, but it will tell you how things are in terms of the dizziness. It's called a modified clinical test of sensory interaction and balance. I mean, it's a long name, but it basically have 4 stages. And the first stage, as you can see, we'll see in the video as well, it tells you how the different systems interact.
It's carried out in 4 sensory conditions. First, as in the Romberg test, the patient stands quietly with eyes open for 30 seconds. And then eyes closed. Note any sway or falls as you would in the Romberg test. The next condition involves making proprioceptive input less reliable. Foam is commonly used. Again, the patient is asked to stand as still as possible for 30 seconds, firstly with eyes open, then with eyes closed. This is quite difficult, even for those without a balance problem, so always make sure your patient is safe. Here, the pattern of performance across each condition will show which inputs the patient is able to use.
So as you can see here, if the patient is standing up, opening eyes, then they are using the 3 systems, the vestibular, the vision, the proprioception. Standing up, closing the eyes, then you have eliminated the vision, and they are using vestibular and proprioception. Standing on the foam or the cushion with eyes open, they are using only the vision and the vestibular system. And standing on the foam with eyes closed, they are relying only on the vestibular system. And while this test, so if the patient sways and fails the test, doesn't give you necessarily a diagnosis, but I find that it is a negative one is very much reassuring, because if the patient can stand on cushions with eyes shut, then I'm almost sure that their vestibular system is normal, because that's the only system that they are using in such a condition. Of course, occasionally, if the patient is very young and they are very active, so they play sports or something, they can do that while they had a vestibular neuritis in the past, but that's not the normal. There are other tests that you can do if you feel that there is a suspicion for them. For example, fistula test, Valsalva, if the patient reports in the history that they go dizzy when they cough or sneeze. You can test the deep sensation if you suspect deep sensory loss, especially in diabetic patients. You may need to find a 128 hertz tuning fork. A lot of times I feel the pulse of the patient, just make sure that we're not missing any irregular or AF heart rate, blood pressure lying down and standing up. I do it almost routinely for all the patients, because as I said, these things can be the cause of the symptoms in some situations, but more often they are playing a part in the patient's symptoms. So these are the tests, and Abdurrahman wanted to focus on the vestibular function tests. So I'll try to go through the important
take
ones.
A rest and take your breath first, Mr. Youssef. Just to remind you again that this grand round is can give you 1 CD point from the Royal College of Edinburgh. So anyone who wants a certificate, please write your email now in the comments, and we're going to send you the certificate as soon as possible. And the second announcement is the airway emergency airway training on the 7th of December. Unfortunately, it's completely full. We have around 40 participants up to now, so it's we cannot accept more, but we decided to do also the same thing, that we're going to send you a link. Anyone who wants to attend it through the link, we can send you the link on the day before. Also, the 7th grand round with Professor Bindi Sahuta will be after the course at 5 o'clock. So both of them, both links will be sent to you through the emails. You can take a nice deep breath and start again.
All right. So in terms of the vestibular function tests, so I've listed here the ones that are the common ones. I mean, there's definitely a lot more. And I'm going to go through quickly the 3 more readily available testing around the UK here. So we've got, of course, the video nystagmography, or the VNG, the vestibular evoked myogenic potentials, the VEMPs, the video head impulse test, or the VHIT. There is definitely a rotatory chair, the subjective visual vertical, and the computerized dynamic posturography. I think the computerized dynamic posturography is present maybe in 1 or 2 centers across the whole of the UK. So we're going to go through the tests and just consider how helpful they are. And just remember when we talked about looking at the dizzy patient as a jigsaw puzzle. So we've got here the different parts of the inner ear. So we can test now the 3 semicircular canals through the VHIT, and we can test also the lateral semicircular canal through the calorics and the VNG. We can test the saccule with the cervical VEMP, and we can test the utricle with the ocular VEMP. So theoretically, we can test each single part of the vestibular system with a test at the moment, but things are not as encouraging as they sound at the moment, but it's still, they are very helpful. So in terms of the VNG, or the video nystagmography, as you can see in the photos here, the patient sits down, they put on video goggles, and they look at this bar of where red dots starts to appear. And the video nystagmography assesses few parameters. So first of all, under the video goggles, the audiologist or the scientist that is doing the test is able to, as we said, examine for nystagmus. And as we mentioned before, we examine for nystagmus under without fixation. So, for example, if a patient suffers from left vestibular neuronitis, they will have right beating nystagmus. Worse, as you can see, because these are the nystagmus tracing that will come up on the video nystagmography, when they look towards the fast phase, less and they look straight ahead, and even less looking to the slow phase. If somebody has got a stroke or a central problem, then they would have a bidirectional gaze evoked nystagmus. So if they look to the right, they've got a right beating nystagmus. If they look to the left, they've got a left beating nystagmus. Then the scientist or the audiologist is going to move on to do, again, the oculomotor testing that we did clinically. And in this situation, the patient follows the red dot, which goes into a smooth sinusoidal rhythm. And you get the report with this graph on it. So the regular graph is the point or the dot that the patient's following, and the blue one is the patient's traces. And the computer of the software of the testing plots this graph in that way, where the dots is if they are outside the shaded area, then these are normal, and if they fall inside, this is abnormal. And in terms of, they move on to the saccades, where again the patient is looking at the bar for and the dots start to appear in a random positions, and the software with the video goggles can analyze few things with the saccades. So again, these are the dot itself, and the blue one is the patient following the dots. Then again, they can come up with the saccade accuracy, how accurate the patient was, the latency, how long it took for the eyes to follow the target, and the velocity and the speed as well. If the dots are in the unshaded area, that's normal. If it is in the shaded area, that is abnormal. So if the report shows that the patient has got defective smooth pursuit or saccades, These are suggestive of that our patient has got central pathology, but I have to say that it is not necessarily 100%. It's about 50%. Then the audiologist would move on to the calorics. And as you all know, the caloric testing, we use bithermal, so we use a irrigation, or which is water, or sometimes air calorics. And it is in, there are two irrigations, one that is at 7 degrees above normal temperature, which is 44, and 7 degrees below normal body temperature, which is 30. And we do the same on both sides. This thermal stimulation causes nystagmus, and the software picks up the nystagmus. As you can see here on the chart, all these dots are actually nystagmus points. And what the software detects is the peak of the slow phase velocity. So the software measures the slow phase velocity, the slow phase of the nystagmus, and then it gets the peak. The same for the right side, cool, the right side warm would do the same. And a graph is formed like this. If both sides intersects within the box, then that's normal. If there is deviation to the outside, then this means unilateral weakness. And of course, you must have read how the formula is done, where we compare or subtract the one side responses from the other side responses and get the percentage. If it is more than 25%, this means that there is unilateral weakness. It has to be said, just to mention here, is that ideally, while the computer calculates the peak of the slow phase velocity, but you want to have all accurate responses. So the peak has got to be accurate. And to say that this is accurate, this is, for example, if you look at the right side, this is a normal response where after a little bit of irrigation, the patient starts to get some nystagmus. Then the nystagmus slow phase velocity starts to increase, and then it starts to die down. Sometimes audiologists or the tester, for any reason, if you get what we call an abnormal result, one shooting nystagmus here, for example, and they leave it without removing it physically, then the slow phase velocity calculated by the computer would be exceptionally high in a kind of not a reliable way. So the audiologist or the tester have to make sure that they are getting the peak in a normal pattern. Again, the same way here. So the peak is following the expected pattern. If you get an outlier, this has to be erased, because otherwise it will significantly change the results of the test. And before we move on, the calorics, as you all know, it tests the lateral semicircular canal. But the calorics are what we classify as a slow stimulation. And it is different from what we're going to discuss next, which is the video head impulse test. So the VHIT, which is the testing or the computerized testing, similar to the head thrust sign that we just saw the video for, and it tests the semicircular canals in a more rapid or a higher frequency rate compared to the calorics. So in other words, when we test the lateral canal with the calorics, it's a slow frequency, and this is not actually a replication of the day-to-day life. It's the VHIT is more of similar to the rapid quick movements that we do during the day. So basically the video head impulse, when the head is rapidly and passively rotated to one side, the eyes move an equal and opposite distance to the opposite side to maintain the gaze on target. And that's basically the vestibulo-ocular reflex. This test measures the eye velocity with a pupil tracker, the same as the video goggles, and compare it to the head velocity. And if we look here, for example, the head movement is delivered on each in different angles to stimulate the different canals. And that's why one of the good things about the VHIT is that it tests each individual canal. So for example, if we want to test the lateral semicircular canal, the head would be flexed slightly 30 degrees and the movement would be side to side. If we want to test the posterior semicircular canal, the head would be turned to one side and the movement would be almost up and down in the direction perpendicular to this canal that we're testing. And the anterior or the superior canal, the head would be to the opposite side and be downward movement. And because when the head moves towards the canal, it causes excitation of the canal, but at the same time, it inhibits its opposite. So that's how the test is selective of different single canals. So that's an example of the report that we get from the VHIT. There is the graphs on the side here, and there is also the gain on here, and we'll come to that in a second. So there are two main parameters that these tests measure. The gain, which is a ratio between the eye velocity and the head velocity. And as we mentioned, when the head, for example, if we look at this patient, when the head is turned to the right, the eye automatically would go to the left to stay fixating on us or on the target. So we measured the ratio between the eye velocity and compare it to the head velocity. Ideally, it should be 1 because the amount of distance and the speed of the head to the right should be equal to the amount of distance and speed that the eye did to the opposite side to maintain the gravity. To maintain, sorry, the image or the target on the back of the retina. And the second parameter that gets measured is what we call the refixation saccade, as we saw on the video. The thing is, there are two types of refixation saccade. So if you look at the same person here, when his head was turned to the left, his eye initially went to the left and then he refixated. So that's what's called the catch-up saccade. So if we look at the graph that we get, the red is the head velocity or the head movement, and the black is the eye movement. So for the right side, when his head was turned to the right side, there's no saccade. It was just following the head. The eye was following the head. On the other side, if you look at, this is the head, the red one, the black one, if the refixation saccade happens well after the head has gone back to its position, or went to the position, this is what we call overt saccades, because basically what happens is that the patient's head went to the left, and then after that, the patient refixated. So this is what we call the overt saccade. Overt because you can see it, because it happened after the head movement. But if the patient was actually compensating and getting better, what happens is that as you are moving the head, there is a bit of a lag from the eye, but the refixation happens quite quickly before the head movement is finished. And that's why the refixation saccade happens while the head is still, or the limb, the descending limb, while the head movement is still happening. And this is called covert saccade because you can't see it clinically. So again, this is just a similar graph. The blue one is the head velocity, the green one is the eye velocity. And as you can see, the refixation saccade, the software can tell you exactly when it happened, what is the latency at milliseconds. And as we mentioned, the gain is measured by dividing the eye velocity over the head velocity, and ideally it should be 1. Again, similar picture here. So this is our covert saccades because it's happening while the head is still moving. And these are the overt saccades. And as we mentioned, the covert saccades actually it's a function of the cerebellum. So in other words, it's not something that is done voluntarily by the patient. It is non-visual, so it happens before the retinal error is detected by the visual cortex. The overt saccade, what happens is that the patient himself or herself notice that they have lost the target, so it is visible to the naked eye, as we said, and also it happens after the head trace reaches the baseline, and it is visually driven. So it is almost like a conscious cortical decision to refixate on the eye. So if we look at an example of the test that we get, the patient has got left peripheral vestibular loss, then they have got a defective vestibular ocular reflex, This means that rapid leftward head rotation would be accompanied by slower VOR, then slower eye movement and reduced gain. And this is how it looks. So the right is the red, but the left, which is the defective, the X here is the average, because the audiologist would do multiple head turns to get a result. So this is the average. If the average is outside the shade or the two lines here, this means that it is defective, and the gain is below 0.8, which is abnormal. You would expect that with the low gain, that there will be either covert saccades or overt saccade, depending on the degree of the compensation. But the same patient had normal eye movements on the right side. So how accurate is the V hit? So it differs actually according to the pathology. So for example, in cases of vestibular neuronitis, it has got a high yield. So it's 97% of cases will be detected as abnormal. Vestibular schwannoma, 71%. Normal or close to normal testing in most strokes, Meniere's disease, vestibular migraines, BPPV. And we found that the Meniere's disease is more sensitive to the calorics, or the calorics is more sensitive to Meniere's disease compared to the V-hit. So in other words, you may have a patient with Meniere's disease, they've got peripheral vestibular dysfunction, you get an abnormal caloric, but a normal V-hit. In other words, the calorics and the V-hit are not really, they cannot replace each other. They're more of a complementary testing. So some places are started now to use the V-hit machine in the A&E because of the high yield. And as you can see, as we said earlier, if you're in an acute stay situation, patient is severely dizzy, you are meant to be able to see a positive head thrust test. So if you've got a computerized one, this will give you a bit more, of course, accuracy. If we move on to the third test, which is the VEMS, or the vestibular evoked myogenic potential. From its name, it is muscle potentials, and they are evoked by vestibular response. So basically, sounds are used to stimulate the inner ear, which in certain frequencies and certain decibel level would stimulate parts of the inner ear that would induce or evoke a potential in the muscles. We've got two types. One is the cervical VEMP, the C-VEMP, and it depends on the vestibulocholic reflex. So the V-hit and the calorics depend on the vestibulo-ocular reflex, but there is also the vestibulocholic reflex, which controls the movement of the neck muscles that affects or controls the head eventually to keep us balanced. So if we apply sound, intense air conduction or bone conduction clicks or tones at 95 to 100 dB at 500 Hertz, this would stimulate the saccule. And as you can see in the picture here, we put electrodes on the sternocleidomastoid, and this is how the VEMP looks like. So there is initial inhibition at 13 milliseconds, it's called P13, and then a positive wave at 23rd millisecond, and it is called N23. Asymmetric C-VEMPs or absent C-VEMPs could indicate an abnormality in the saccule or abnormality in the lower or inferior vestibular nerve. If you look here of the percentages of C-VEMP picking up diseases, it's abnormal in 40% only in vestibular neuronitis, 40 to 60% of Meniere's disease, and 50 to 75% in vestibular schwannomas. It is less common in vestibular migraine. In terms of the superior semicircular canal dehiscence, which is one of the very good indication for this test, the reason why it is impaired in superior or is abnormal in superior semicircular canal dehiscence, while we said that it's mainly stimulates the saccule, is that with the presence of the dehiscence in the canal, the presence of the hole in the bony labyrinth, this allows space for the membranous labyrinth to bulge through it with the sound. And that's why patients with superior canal dehiscence have got this Tullio phenomenon, because the sounds basically can push the membranous labyrinth through the defect in the bone. This allows more movement of the inner ear fluid, and that's how the stimulation happens. And that's why it's not lost in the superior semicircular canal dehiscence. Actually, the graph, if we go back to it, you will find, you will find that the amplitude is bigger. In other words, the sound that is produced to the ear, and instead of producing a normal curve, actually the movement inside the inner ear would produce a bigger amplitude. And it's not just the amplitude that gets measured, but also the threshold, because as we mentioned, we use 95 to 100 dB clicks to evoke this potential. You may find that with the superior canal dehiscence that it can go down to 85 and maybe even 80. In a normal ear, if you go below the 95, you will have no reflex. So with the superior canal dehiscence, the CVEMP shows higher amplitude and lower thresholds as well. The ocular VEMPs, it's a different type of VEMPs, but instead of putting the electrodes on the sternocleidomastoid, it is beneath the eye. And using the bone conduction thresholds here, it stimulates the utricle. So again, the difference also is that the ocular VEMPs, it's not ipsilateral, so it's actually crosses. So if you've got an abnormal ocular VEMPs on the right side, this is a defect in the left utricle. And as you can see here, ocular VEMPs are abnormal in 50 to 70% of vestibular neuronitis. And the reason that it is more sensitive compared to the CVEMPs, which is only abnormal in 40%, is that it is known that vestibular neuronitis is more commonly to affect the superior vestibular nerve, which is tested by the ocular VEMPs because the utricle is supplied by the superior vestibular nerve more than the inferior vestibular nerve. And it is 10 to 50% of Meniere's disease, low in vestibular migraines. And these are the difference between the CVEMP and the OVEMP. As we mentioned, the CVEMP mainly saccular and the OVEMP mainly utricular. Also, the CVEMP tests the inferior vestibular nerve. The OVEMP tests the superior vestibular nerve. The CVEMP is ipsilateral, so it is the ipsilateral sternomastoid. The OVEMP is contralateral responses, and this relies on the vestibulospinal reflex, and the other one is on the vestibulo-ocular reflex. So as you can see from the previous testing, the three of them, which are all of them are readily, to an extent, readily available in different centers, but none of them has got a 100% or very high specificity at all. And that's why if you look at all the diagnostic criteria for vestibular neuronitis, Meniere's disease, vestibular migraines, none of these would involve testing. So there is no test that we do that tell us that this is a case of Meniere's disease. No test that we will do that will tell us that this is a vestibular migraine, for example. So the problem that happens when we see cases of episodic spontaneous vertigo, as we all know, this could be vestibular migraine, could be Meniere's disease. Migraines can be presented as episodic spinning, rocking vertigo, could be lightheadedness, and often it is time locked with migraine headaches. Meniere's disease have got the usual tetrad of symptoms. So what about the isolated spontaneous vertigo without oral symptoms or migraines? If you look at the abnormalities in the testing, so we normally do an audiogram, do caloric testing especially for Meniere's disease, and then we look at the cervical or the different VEMPs. Meniere's disease, as we mentioned, caloric asymmetry in 61 to 66%. Vestibular migraines are a lot less. CVEMPs with the Meniere's disease, higher 38 to 64% that they become abnormal. With the vestibular migraines, less, and even more with the ocular VEMPs. At the end, if all these tests, you've done these tests and they are normal, it is reasonable to treat the patient as vestibular migraines. Having said that, there have been, of course, cases where these tests were normal and the patient ended up being Meniere's disease. So the things to consider, vestibular function tests will not give us a definite diagnosis. As I mentioned earlier, you want to put all the jigsaw pieces together to be able to see. So the history, the examination, and sometimes if you need the investigation. So it acts as an adjunct rather than a definite test. And I would say consider vestibular function tests with difficult to diagnose cases before you do an invasive procedure. If you're going to inject patients with medication, do an operation, or post-treatment failure or relapse. And I have to say that there are two schools here, and I think to my mind, the correct answer is in between. So one school says, no, these vestibular function tests, I don't do them at all. They are useless. Other school would do vestibular function tests to every single patient. And I think the truth lies in the middle. I have to say just one last thing is that you have to be careful when we do the vestibular function test. They can sometimes give results that are difficult to interpret. So of course, if you see, and we all do sometimes, we see the difficult patients where you don't know what's going on. You think that there is a high psychological overlay, and you say, okay, I'm going to send them for a V-hit. If it comes normal, I'll tell the patient, your tests are normal, go away. The problem sometimes happens if you get the results and says you've got high or low gain in the right posterior canal and there is some catch-up saccade in the left anterior canal. You won't be able to interpret these as a meaningful results, and then you will be in a situation where you've sent the patient for a test that came back as abnormal, and those kind of patients would latch on to either have had an abnormal test, and then you become almost kind of obliged to treat me because of these abnormal testing. So what I want to convey is that vestibular function tests are very helpful, but they're not really the only answer to the difficult patients. This is just an acknowledgement for Fiona Barker. I've got her permission for the videos, so any questions I'll be happy to answer. Thank you.
Thank you, Mr. Youssef. Really great. A good refreshment for myself as well, for everyone. I think so. We have around 65 participant doctors in the grand round, which is really great. Myself is my question is for you is the same. Do we need to have this as a mandatory for everyone, or sometimes you think that this is a multifactorial person? I'll send the patient mainly for the physiotherapy, for rehab, and maybe if the patient didn't get much from the rehabilitation, I would do the vestibular function test. Or you think that we discharge the patient and just for the physiotherapy? What do you think about those complex patients?
Let me just stop sharing. So I think Abdurrahman, it depends on the patient, of course. You would want to so a lot of times patients like, and it's understandably anyway, to have a diagnosis. So if you tell them, for example, that we don't know, I'm just going to send you to a physiotherapist, it's unlikely that they will be satisfied and unlikely to work. And knowing the different potential diagnosis, as I said, sometimes I feel when I'm sitting in the clinic, my role is ruling out that could be something else, not ENT related. So, and a lot of times when the patient is, as you said, multifactorial, explain this to the patient, try to correct all the correctable factors. So including things like anemia, for example. So the patient would be an 80-year-old, they've got ischemia, cerebrovascular ischemia. They are a little bit anemic on different medications. So these multifactorial things, there will be things that you can't correct. So if they've got severe arthritis, they've got macular degeneration, you can't really do much about it. But if there are symptoms that you can correct, then I think they ought to be corrected. And a lot of times I tell the patients that we have to be also practical when it comes to these situations. What actually can we do? If we can't reach a definite diagnosis that can be treated with a medication, for example, or if, for example, their blood pressure or heart rate, or and it is not a surgically, so it's not superior canal dehiscence, it's not Meniere's disease, it's not a surgically treatable condition, then we are left with a trial of vestibular rehabilitation. Trial of vestibular rehabilitation would definitely harm no one, and there is a significant possibility that the patient's condition may not necessarily completely go away, but it will be better, because a lot of times there is, as we mentioned, psychological overlay in terms of loss of confidence. They fear that I don't want to go out, and then they start to deteriorate in terms of the activity. But having some physiotherapy that can give them some confidence in improving, and again, setting the patient's expectations to a realistic expectations helps a lot. Sometimes you get patients coming and say they are 80-year-old, I can't dance anymore. So you'd say, okay, this is obviously a patient lacking insight about their age. They want to dance. I had once a patient said that I can't go on the trampoline. He's 60. I can't go on the trampoline with my grandchildren. So having a realistic expectations is quite helpful in making patients a bit more satisfied, I guess.
Okay. Anyone else who would like to ask, he can unmute himself just and then ask the question directly. There is no problems. I still remember your advice about the multi-focus and the bifocal glasses, and I have a lady 2 weeks ago, and this is the second time she said that, doctor, when I change it to reading glasses and the walking glass, I find myself better. As I say, yes, I told you from the start, I don't advise for anyone feel dizzy or off light to wear those, because sometimes it deceives your brain. And she said, oh, thank you for this. Anyone want to ask? Is it Mr. Adimi?
Yeah. Thank you very much for a very comprehensive talk.
Thank you.
And very insightful. It's been very helpful. My question is about timing. Well, if one is practicing in a district general hospital, in the light of what you have said, and there is not a number of support, the clinical history, examining the patient, what's the length of time you think would be reasonable? Average time here is 15-30 minutes. To do a distance assessment of a dizzy patient, what would be your advised allocated time?
Yes, so it is a very common question that I get after such a presentation. The thing is, you are absolutely right. So to say that I'm going to see a dizzy patient in 15 minutes or 20 minutes, that's not going to happen. Especially a lot of them, especially if they have been dizzy for 10 years, they come in, expect you to tell you what happened over the last 10 years. Some of them would break into tears, and to be able to have a proper history, examine them in 15-20 minutes is unfair, and it is very difficult. So that's why my advice would be for anybody working in any hospital is actually to avoid these situations where you are half an hour or an hour behind, and then you see a dizzy patient who wants to chat and blabber about how difficult life is actually to ask to set up a balanced clinic. Because when you do, you will have a control of the template, because this would be considered as a specialized clinic. And I have to tell you that I think in anywhere you work, there will be a significant support from the rest of the department if a balanced clinic is going to be set up. Because about maybe 12 years ago, we did an audit, and it just shows you how difficult some of these things are. And in about maybe 3 months, there was, I can't remember the exact numbers, but there was 120 balanced patients, dizzy patients, came to the ENT clinic, and we audited who actually saw those patients. We found that the consultants saw 3 patients. The rest of the patients were seen by the middle grade, so whether the registrars or the specialty doctors. And the reason being because the consultants, they see the referral, find out that's a dizzy one, pass it on. So it just tells you that it's not you know, it's not something that each individual would feel. It's actually across the board. So what I do, for example, here, when I first joined, is that I asked, I'm going to set up a balance clinic, and because this is a specialized clinic, I want at least half an hour for every new patient, and that's how you can treat these patients. But otherwise, you will be stressed. You will hate seeing these patients in the middle of the clinic, and they won't be satisfied because you need to see the other one. So I think for a new patient, definitely half an hour is the least. I ask half an hour for a new, 15 minutes for a follow-up. And if I've already done all that in the new patient, the follow-ups normally take even less than that, because you're not examining them again. And this way you can even sometimes have some extra time to see a difficult, troubled new patient.
Thank you
Okay,
very
so
much.
Faris was asking about what do you do for Meniere's? Do you do the VHET and the caloric, or anything
Yeah,
else?
if as you probably know, Faris, the diagnostic criteria for Meniere's includes the hearing test and the description of the dizziness. So I don't necessarily routinely do vestibular function tests to the Meniere's patients unless I am going to intervene. In other words, if I see a patient and they get better with a diet control, possibly beta histine, fine, we stop at this stage. We keep an eye on them I normally keep hold of them for a year. And if the episodes are controlled, fine. If they're not controlled and we're going to move up the ladder, then I would ask for, especially before we do anything like injection of the eardrum or sac surgery or whatever you're going to do, if there is either if there is no improvement or if there is intervention that I'm going to make, I'll probably get a vestibular function test. We can, and as I mentioned earlier, a caloric is important, and the caloric and the VHIT are normally complementary. So if I request for a Meniere's patient, that's probably going to request both of them.
Thank you, Mr. Arthur. Thanks. It's we on the time, and thank you for your great presentation. Amazing, to be honest, and really refreshing to me. And I think it's new information and refresher for all of the attendee. I said there is a quite number of people here, and believe me, a lot of people will see it in the on the YouTube as well.
Right.
But we think we need to see you again in another interesting skull-based topic.
Hopefully.
So
All right. Thank you very much.
In a couple of months, take a rest
Yeah.
from us, but in a couple of
right.
months for sure. Okay.
Thank you, Abdurrahman. Thanks.
Inshallah.
Thanks a lot.
Yeah.
See you on the
So,
Goodbye. Bye bye.
Thank you.